Well, palliative care in many ways, Mary, has been around for a long time. I mean, we could look at the sisters in Harold's Cross who are there 150 years providing compassionate care for people at the end of their lives. But in the more defined understanding of it, really, it's now become a branch of medicine which would be defined as providing holistic care, which would mean emotional, spiritual, physical care for people probably in the last year to year and a half of their lives. And it also includes care of the families, so it includes caring as well for the partners, the friends, the relatives, while they're caring for somebody while they're ill, and then right through into bereavement, maybe for about a year after the loss as well.
I think there's been I suppose, view that really palliative care is terminal care, which is the care for people at the very last days and weeks of life. That isn't the case.
Palliative care isn't new, but I suppose what is new is the fact that it's not just focused on patients with cancer, that it's now available for patients with any life-threatening illness.
Palliative care is delivered at home, in people's homes. It's delivered in hospital situations. There are specialist palliative care teams in many of the acute hospitals, and palliative care is also delivered in hospices or specialist palliative care units.
Palliative care to me certainly is open to anybody, whether they're a newborn baby, whether they're a 10-year-old teenager or a 10-year-old boy or a 15-year-old teenager, or indeed an adult. It certainly is not limited by age.
I think what I've come to learn from working in palliative care is really that the team put the patient first, the quality of life of the patient, and they give as much time as possible to the patient and to their family to make sure they get the best support.
Our focus is very much on comfort and quality of life and on the individual person. We are very focused on the family as the unit of care. The family is whoever the patient says they are. It's not about blood relatives necessarily.
The public definitely don't know enough about palliative care, and I think that is a big challenge, and people are afraid of the word palliative care. They're afraid of the word hospice because of what they have in their head that it means, and it doesn't mean the end.
When you come to a hospice, you'll be met first of all by a doctor and a nurse who will assess your needs, meet you and meet your family, and take time to talk to you about what's going on, about your symptoms, about what's difficult, what your aims are and what you want from your stay here in the hospice. The doctor and the nurse will then refer you on to the wider members of the team based on your needs. You might meet the occupational therapist, the physiotherapist, the social worker, the chaplain. You'll meet the household staff, the volunteers.
Some people do prefer to be in their own homes. Some people don't, and everybody is very different. So part of our role is assessing what the person wants to do, what are their wishes, and also what are the family's wishes. Palliative care is very much about the person, but it's also about the family and the other people that are involved in the care.
I don't think anyone can necessarily take the pain away or take away sadness. People will experience it and will suffer it. But from our point of view, we will try and explore ways of supporting people with their sadness.
As a chaplain, I would see my role as being there for people, being present to people, being a person there who's able and willing to listen to them.
Well, it's very important that the person actually feels autonomous, that they have that autonomy and they have that ability to actually have some control. Often when I meet patients for the first time, they've been on a journey with their illness and they can feel that, goodness, the control has been taken away from them. And what I often try to do is talk about giving them back the reins, that they feel again that they actually have some control over what's happening, because after all it's happening to them.
Nowadays people are looking at palliative care not being coupled to a building, because I think in the past we've thought of palliative care being in a hospice. Now we want to kind of uncouple that and see palliative care as something that's delivered across a whole range of settings.
There are many patients that come in to the hospice for a short period of time in order to get in control of a particular symptom or a particular problem, for example for pain management or nausea management.
They're more likely to come in, have treatment and go home again. And so they may come into the hospice 2 or 3 times. And that's really important, because one of the things that Cecily Saunders actually said was, our role is to help people live until they die.
A typical day for a patient in the hospice may depend on what area of the hospice they're in. For example, in the inpatient unit, the day is very much structured around what the person wants to do and is able to do. So for example, if they're tired in the mornings, they may sleep on in the morning and then get up in the afternoon. In the hospice day care, there isn't really a typical day. There is a structure, but anything can happen. When somebody comes in at 10:30 in the morning, they're welcomed with maybe tea or coffee. They're seen by one of the nurses and have a full nursing assessment, and then whatever else they need during the day. There's lots of nice things as well. They may have their hair done, their nails done, go to an art class, perhaps some complementary therapy.
Specialist palliative care is delivered by quite a wide team with a number of disciplines, including doctors, nurses, physiotherapists, occupational therapists, speech and language therapists, complementary therapists, volunteers who play a very, very important role and give so much of their time.
Volunteers in palliative care, to me, add the cream on top of the cake. They offer so much. They offer people lifts into clinics. They bring the drinks trolley around. They go down to the betting office for somebody. They befriend, they read stories to people.
We would work very closely with oncology departments, we would work very closely with neurological departments, and indeed respiratory centres, cardiac centres. Whichever condition the patient is experiencing, we would be working alongside that department.
It's not about just exclusively medicines, it's about living well within a condition, within having a condition.
Children, respite needs is a tremendous part of palliative care. They need to dip in and out of palliative care. Their needs aren't because they're necessarily actively dying, it's because they're going through a particularly tough time in their illness.
All our GPs in this country would know how to access services, because we're very fortunate in Ireland in that every county now has access to a palliative care service.
People come from all sorts of different religious and cultural backgrounds, and to deliver care and develop a care plan that's appropriate for that person.
We celebrate a lot here, and like the celebrations might be a birthday, it could be an anniversary, it could be a christening. We've even organised weddings.
Ireland ranked 2nd in the world in terms of palliative care service delivery.
Any decision affecting a patient will be discussed with that patient, and the patient is really at the centre of the service. And so whether or not you meet different professionals or people within the service is very much up to the patient or up to the family involved.
It's very important to involve the person themselves, because often, really, I suppose in reality, they're the lead on our team. It's their needs that we're trying to meet.
Palliative care doesn't stop when the individual dies, I think, and particularly with children that have a life-limiting condition that unfortunately do ultimately pass away. Over many years they may have built up huge relationships, very strong relationships with a lot of professionals, nurses, doctors, etc. And certainly my role as a nurse is to ensure that the process of caring for this family continues beyond the death of a child.
With the new treatments that have come on board and that are continuing to come on board, people are living longer with conditions, and it's living with the illnesses. Therefore, we tend to be involved for longer periods of time with them. So it can vary from a short period of time to years.
Death essentially is the counterbalance to life. It is what gives our lives tremendous depth and meaning. So I think it's so important that we understand it and embrace it for what it is.
Palliative care is a human right. It's not an additional thing that we should be giving to a select few. It's a human right that every member of our society is entitled to.
The team put the patient first, the quality of life of the patient, and they give as much time as possible to the patient and to their family to make sure they get the best support, and I think really it is very vital to people. So I think that's the best part of palliative care.
As well as living longer, people have better quality of life, and so yes, it is good for you.
The involvement of palliative care will actually lead to people living better and living longer.
If we can show that we care well for those who are sick and dying, then I think we're saying something very much about who we are as a people.